A 32-year-old male came with complaints of asymptomatic brown patch over left axilla. He denied history of contact with chemicals. The first clinical picture shows you a large brown patch over left axilla, and the second picture is a fluorescent picture under Woods lamp examination. And your options are tinea axillaris, erythrasma, impetigo, and pityriasis versicolor. And the answer is yes, erythrasma. Why not tinea axillaris, impetigo, and pityriasis versicolor? No. Tinea axillaris is a condition in which patient experiences severe itching. On clinical examination, you are able to see many papules distributed along the borders with more erythema and with central clearance. So tinea axillaris is ruled out. Next is your impetigo. Impetigo is a condition in which a patient will have severe pain and tenderness. On clinical examination, many vesicles, pustules with discharge. Sometimes they have honeycomb-like crust, right? So impetigo is also ruled out. Next is your pityriasis versicolor. Pityriasis versicolor is another asymptomatic condition, and its hyperpigmented variety looks like your erythrasma. Then how will you differentiate these two is erythrasma will involve vault of axilla. Hyperpigmented variety of pityriasis versicolor will not involve vault of axilla. Erythrasma under Woods lamp examination reveal coral red fluorescence because of the release of coproporphyrin 3. In pityriasis versicolor, they exhibit yellowish green fluorescence because of the release of pityriolactone. By this way, you can differentiate between these two asymptomatic conditions, right? And the answer is yes, erythrasma. Then we'll have a short discussion about erythrasma. Erythrasma, you all know, caused by Corynebacterium minutissimum. It is very common in tropical climates and common over sweat occluded areas such as axilla, groins, and toe cleft. Clinically, it is characterized by asymptomatic, well-defined reddish-brown patches. New lesions are smooth and older lesions are finely creased. Right. Under Woods lamp examination, it exhibits coral red fluorescence. How will you remember this? Erythrasma, in the name itself, erythema. So, coral red fluorescence due to the release of coproporphyrin 3. For every suspected cases of erythrasma, you should send the patient to Woods lamp only before bath, not after bath. Why? And the answer is, if you send the patient to Woods lamp after bath, the fluorescence will be negative. This is because the coproporphyrin 3 is water soluble, so it is washed off after bath. So for every suspected cases, you should send the patient to Woods lamp only before bath. This is very important. Next, treatment is topical 2% clotrimazole and miconazole can be given. For extensive lesions, you can give oral clindamycin or erythromycin. Why antifungals for a bacterial infection? And your answer is 2% clotrimazole and 1% miconazole will have mild antibacterial effect against your staphylococcus, streptococcus, and Corynebacterium. Right. What are all the points to be remembered here? Erythrasma, Corynebacterium minutissimum, common over sweat occluded areas, clinically well-defined irregular reddish brown patches. So topical treatment is 2% clotrimazole, 1% miconazole. For extensive lesions, oral clindamycin, erythromycin. How will you differentiate erythrasma and pityriasis versicolor? Erythrasma involve vault of axilla, pityriasis versicolor won't involve vault of axilla. Erythrasma, coral red fluorescence, here yellowish green fluorescence, here coproporphyrin 3 in erythrasma, in pityriasis versicolor, pityriolactone. Right.